Hi, and welcome to complex chronic cases from the Leeds General Infirmary. This is a case of a calcified LAD chronic tensor occlusion treated with rotational atherectomy. My name is Dr. Abdul, I'm a consultant cardiologist at the Leeds General Infirmary, and this procedure was performed as a proctored case with my colleague, Dr. Jenny Rossington. So this is a case of a 72-year-old male who had undergone previous coronary artery bypass surgery with limb-to LAD and vein graft to his circumflex and right coronary artery. He had persistent angina following his bypass surgery and was found to have 5-segment residual LAD ischemia. Diagnostic angiogram showed that the limb was in fact occluded, and the native LAD was a chronic tensor occlusion, and he was referred for PCI to this. This is the native left system showing diffuse disease in the proximal LAD. This is a large septal, and in fact the LAD is here with a short calcified occlusion, and the distal vessel is here and fills via ipsilateral collaterals. The occlusion length appears relatively short, although angulated at probably the lemur anastomosis. This is the vein graft and circumflex, which is patent. This is the vein graft to the distal RCA, which is also patent. So he was referred for the procedure. We attempted to perform this using radial artery access, but due to calcification, it was not possible to advance a guided catheter, even using balloon tracking technique, as here demonstrated here. So this was unsuccessful. So we switched to 7 French femoral access using ultrasound guidance to access the femoral artery. This is ultrasound guidance to puncture the femoral artery using a micropuncture kit. You can see the femoral artery is calcified. The left radial artery was not palpable, hence the reason for femoral access. This is the femoral artery showing reasonable puncture but diffuse diseased artery. So proceeded to PCI using a 7 French Vodo left 4 guiding catheter. And ACT guided heparin. So here are the setup shots. This is an AP quarter view. Diffuse disease proximal LAD. There's some disease into the left main stem. And this is the AP cranial view. You can see the LAD CTA, which is probably a short occlusion just after that large septal branch. There is, in fact, significant proximal LAD disease, which will likely need treating, as well as distal left main stem disease. So the plan here is to perform an antegrade wire escalation technique. We've elected to initially go with a single access procedure, given that this appears to be most likely antegrade wire escalation case. With possible antegrade dissection re-entry as a second line option. So we initially placed a cyan blue wire in the large septal branch to provide us with support and also to give us the option of anchoring if need be, which would appear to be likely given the calcified nature of this occlusion. That's into the septal. So then moved on to wire the LAD using a standard antegrade wire escalation. So this was first a cyan blue to engage the proximal cap, then a turnpike spiral. Well, microcatheter was advanced to provide support and allow wire exchanges. Turnpike was advanced to the proximal cap. This is then a fielder XTA. Our usual wire escalation protocol is fielder XTA XDR, then a pilot 200, and then stepping up to more stiff wire like convenza. So here, if we go the XTA, in fact, you can see it's going up, back up, and that's probably into the occluded lemur. Yeah, just there. So it's trying to occlude across this, and here we are, just managed to go across that. But again, the wire did not feel free. So I managed to just bring it back. And there, just a little jump there. And then the wire suddenly felt very free. And then managed to wire the distal LAD. This is all with the fielder XTA. It was then not possible to advance the microcatheter, even with Antegrade balloon, as you can see here, that the guide is backing out. So we, in fact, elected to swap out this microcatheter for a final microcatheter in the Caravel 135. So the anchor balloon, which was a 2515 millimeter NC balloon, was in fact used for the dual purposes of trapping also. So it's brought back into guide to trap out the turnpike spiral with an attempt to pass a Caravel 135 to see if this would cross easily. The caravel does have a better crossing profile. However, the downside is the tip is more fragile, so it's not to be pushed in or torqued in a very heavily calcified lesions, as there is risk of tip fracture. So here we pass the balloon back into the septal for anchoring. And the myocatheter is then advanced easily into the distal vessel. And given the calcified nature and the inability to initially pass myocatheter, we elected to proceed directly to rotational atherectomy. So is a rotor floppy wire. We use the caravel to exchange for this. Here again, using the anchor balloon as a trapping balloon also to trap out the myocatheter. And we then proceeded to perform rotational atherectomy with a 1.5 millimeter spur. So this was initial rotational atherectomy to the proximal segment. We then performed Dynaglide to pass the rotor burr further into the LAD. It's had quite some resistant lesion, requiring several passes. See, we just crossed the occluded segment. The burr is then removed, and we used the caravel 135 catheter again to exchange for workhorse wire, in this case a Steon blue. Often we just wire parallel to the rotor floppy wire. But in this case, the occlusion was quite a difficult lesion to wire in any case, so it was easier and probably more efficient to use the microcatheter for the exchange. We also put another workhorse primary wire into the septal again for anchoring purposes. We dilated the LAD with a long 2.5 millimeter balloon. You can see the vessel is calcified, but there is adequate expansion of the balloon. At the occlusion point, there is adequate expansion. We also dilated the proximal LAD to left main stem. There's 2.5 milliliter balloon again in the left main stem. We then used a 3.5 millimeter NC for further preparation. This is the angiogram following the first pre-dilations. You can see restoration of antegrade flow into the LAD. A smallish caliber vessel for now, but this is likely to be underfilled currently. So here is the 3.5 millimeter NC balloon. High pressure dilation of the proximal LAD. We then performed intravascular ultrasound to guide our stenting strategy. And actually on intravascular ultrasound imaging, there was not too much disease in the mid to distal LAD past the occlusion point. And in fact, despite having done some pre-dilations distally, we decided to only stent from just past after the occlusion point, where there appeared to be a healthy landing zone on IVUS imaging. So this is a 2.5 by 38 millimeter stent, pulled back and dilated at 20 atmosphere. So here to dilate for adequate expansion. It is just taking a puff to guide the length of the second stent from the proximal LAD to left main stem. This is then a 3.5 by 33 millimeter stent. From the proximal left LAD to the left main stem ostium. There's a good overlap distally. The atherectomy view is usually the best view to assess the ostium of the left main stem. So here we are. So we then move on to the atherectomy. Here you can see a nice view of the left main ostium. Stent was advanced just a millimeter or so. A good position there. The stent is deployed at 16 atmospheres. And advance the balloon just to post-LAD overlap. And here is the proximal optimization of the left main stem with a 4.5 millimeter NC balloon at 20 atmospheres. We use an AP chord review and just take a puff just to make sure we are at the carino of the circumflex and not into the LAD. That's usually the best view to do the pot of the left main stem. Following proximal optimization, we then repeated an intravascular ultrasound and assessed the distal edge of the stent expansion, and the left main stem. And based on this, we found that we needed to do further post-dilations of the LAD to 2.75 high pressure distally. Followed by 4 millimeter NC post-dilations at the proximal LAD and distal left main. This is then the final results, showing excellent result in the LAD with TIMI3 flow in all branches and good stent expansion on intravascular imaging. Thank you for joining us for this case presentation.